Hi, this is Dr. Nick, and we're starting a new section now on atrial fibrillation. As you can see in this pie chart, it makes up over 2/3 of the arrhythmias that we're likely to see in an emergency room, and so it's something that you'd be recognizing on cardiograms quite frequently. So let's talk about what atrial fibrillation is. Atrial fibrillation is an electrical disturbance in the atria where the electrical signals are chasing themselves round and round in different directions in a very disorganized fashion. And people have described multiple wavelets of reentry going round and round in different directions. Now, that's the classic idea of atrial fibrillation. And I'm planning to talk a little bit more about atrial fibrillation and the different types of AFib you can find in the advanced course, because in the last 10 years we've learned quite a bit about atrial fibrillation and where it comes from, and the idea of the trigger foci versus reentry circuits. But for the sake of diagnosing it on an electrocardiogram, I think this mechanism is pretty clear. Now I have my animation here, and I've shown you what looks like this random chaotic electrical activity in the top chambers. Now keep in mind that the AV node is going to pass some of those signals down. It can't pass them all down, but the AV node is designed to act like a safety valve, and atrial rates during atrial fibrillation usually exceed 350 beats per minute. Now the AV node really determines what the ventricular rate is going to be during atrial fibrillation. And we use the term ventricular response to refer to how fast the ventricle is going during atrial fibrillation. So you can have atrial fibrillation with a rapid ventricular response, a moderate ventricular response, or some people call it controlled ventricular response. And you can also have it with a slow ventricular response. And this refers to how fast the ventricles are going, and that's determined by the AV node. Remember, the AV node will not conduct as well at high rates. So even though someone's heart can go quite fast if they're in an organized atrial tachycardia, let's just say, or even sinus tachycardia, put it this way. When someone gets on a treadmill and we get behind them with a cattle prod and we have them run to their predicted maximal heart rate, their maximal heart rate or predicted maximal heart rate is 220 minus your age. So if someone 50 years old gets on a treadmill, you'd expect them to be able to reach about 170 beats per minute. Well, when someone goes into atrial fibrillation, even at the age of 50, it's very unusual to see rates that high. You'll usually see them in the 130 to 140 range if someone has a healthy AV node. And that difference between a predicted maximal heart rate during an organized atrial rhythm like sinus rhythm and the atrial rates during atrial fibrillation has a lot to do with this phenomenon of the AV node conducting worse when the atrial rate is very high and the AV node is being bombarded in all different directions. But just remember, it's very important to understand the concept that the ventricular rate is determined by the AV node itself. I hear a lot of cardiologists, when they see atrial fibrillation with a slow ventricular response, they'll call it sick sinus syndrome because the heart rate is slow. But in fact, you can't really tell what the sinus node is capable of doing because the patient's in an arrhythmia, atrial fibrillation, and their sinus node at that point is taking a nap. Now, if they were to go back into a normal sinus rhythm, their heart rate might in fact be quite normal. The slow ventricular response is more of a reflection of poor AV conduction and AV nodal dysfunction. So just keep that in mind as we go through these tracings. Now, recognizing atrial fibrillation on a cardiogram is actually quite easy because instead of having discrete atrial activity, because you have this continual chaotic activity, what you generally see on the ECG is a very wavy, disorganized electrical signal, and then every now and then you see a QRS complex, but there's no discrete P waves during atrial fibrillation. It just looks like electrical noise, in fact. Now and then, the atrial fibrillation can become very coarse. We refer to atrial fibrillatory waves that are very large as being coarse atrial fibrillation. And sometimes they can get so big that it almost looks like a P wave because it coincidentally lands in front of a QRS complex. But you have to make sure that if you're seeing what you think are P waves, that they're consistent in front of every beat. Those are just a few important considerations. Now let's get to the first tracing. When you look at the forest, what you expect to see during atrial fibrillation is that the ventricular rhythm is irregularly irregular. That means that there's no pattern to it. There's no group beating that you can recognize groups of twos or groups of threes. What you see is maybe 3 or 4 fast beats and then a pause, and you got a couple of fast ones and a little less of a pause and a little bit more. So there's no pattern to the irregularity, and that's why we call it irregularly irregular. Now, when you try to calculate the rate, this is where 3-second marks can come in very handy. The idea is to count up how many R to R intervals there are in 6 seconds and then multiply by 10. Now, this rate is somewhere in the range of 70 or 80 beats per minute when you take into consideration these long pauses. And when we look to see what the rhythm is, we're looking at the baseline and we see all this sort of rapid undulating effect. These little peaks here are less than 200 milliseconds apart. And so the atrial rate is clearly way above 300 and likely faster than 350 beats per minute. Sometimes you get big fibrillatory waves, and sometimes they get to be so small you can barely see them. Look at this long stretch in V1. This is pretty typical for what's known as fine atrial fibrillation, where that means you can see it, but it's very small and it's almost hard to recognize, especially here in V2. So just make sure that you're dealing with an irregularly irregular rhythm, that you see that there are fibrillatory waves on the baseline in between the QRS complexes, that there's not a consistent P wave in front of each beat that you could sometimes see if you're dealing with, let's just say, a sinus rhythm with very frequent atrial premature beats. And the more you see this, the easier it becomes to diagnose because you begin to recognize it almost immediately. And then it's just a matter of analyzing the individual QRS complexes for abnormalities such as IVCDs and bundle branch blocks and so forth. And that's going to be covered, of course, in the intermediate course when we deal with 12-lead ECG interpretation. Well, that concludes this introduction to atrial fibrillation. In the next video lesson, we'll go over more tracings with rapid and slow ventricular response, looking at fine and coarse atrial fibrillation. And then in the last lesson, we'll deal with more unusual kinds of atrial fibrillation, including aberrant conduction and something you've all heard of, but I'm sure you don't understand, and that's called the Ashman phenomenon. So, for the ECG Academy, this is Dr. Nick. Thanks for watching.